features of gastric outlet obstruction and obstructive jaundice. CT scan shows a poorly differentiated mass in the pancreas. FNSA shows an adenocarcinoma, and on endoscopy there is a gastric outlet obstruction as D2, D3. His hemoglobin was 10 with a bilirubin of 14, and this is an MRCP which shows a dilated bile duct along with the dilated intrahepatic ducts and ascites also you can see, and over-distended gallbladder. We asked, first we tried PT-PD, but not feasible due to presence of ascites and absence of proper window. What I did, we put a percutaneous drain into the peritoneal cavity. EUS-guided biliary drainage was attempted, but there was no adequate window for choledochoduodenoscopy because of multiple collaterals across the CBD. And HGS was also not possible because of non-significant left-sided ISBRD and intervening vessel also. This patient has an intrahepatic vessels. So what I did was I did a gallbladder drainage using the hot exhaust, but even after 72 hours, the jaundice was not decreased and the CBD was dilated. So what we did, through the hot exhaust, we put a CBD stent, and within 5 to 6 days, LFT become normalized. So now he has gastric outlet obstruction along with the two stent. One is cholecystoduodenoscopy and one stent through the cholecystoduodenoscopy to the lower end of the CBD. Our plan is to do the GJ using the freehand technique.
Sir, can we have a detail of the last stage? How many coils and how much glue was inserted? There was complete obliteration was achieved in the gastric varices case.
We checked with Doppler, and it turned out that the varices were obliterated with just that single treatment. So 2 coils, and I think we used, was it maybe 2 cc's of the histoacryl? And that was enough to obliterate, and there was no Doppler flow in the perforator or the intragastric varices. So it was a good result.
Very good, sir.
Okay, now I've inserted the therapeutic echoendoscope. I've taken precaution not to push too far in. So you don't want to push into the antrum, because when you pull back, you may pull back your oral enteric catheter. Now this patient already had a nasal jejunal tube placed. So we're going to use that tube actually to fill the jejunum. And I've never done this like this. Usually I place a 8.5 French oral enteric catheter, and I release the pigtail off the ligament of Treitz. And I make sure that on a fluoroscopy, I see the pigtail at the ligament of Treitz, because that's what I want to target, the ligament of Treitz. You have a natural ligament there that suspends or connects the stomach and the small bowel. So it's sort of an area of natural adherence of the small bowel. So I don't know that I have that advantage, but we definitely already have a catheter in position. And when I insert in my scope, I immediately here see a lumen. So this is the small bowel. You can see, very typical.
Professor?
And yes?
For 30 seconds, we want to shift the last part of 30 seconds.
Okay.
Shift to room number 1. So Goenka, you are online.
And what we did is that we went with a balloon catheter this time with a wire. And we are fortunate in the first go, the wire went up, not into the cystic duct, but in the hepatic ducts. And we are engaged one of the stone, as you can see, and it's almost at the mouth of the papilla. So we'll just show you this removal. And I think for the youngsters, again, the direction of pull is very important. You must pull your accessories parallel to the bile duct rather than at an angle from the bile duct. So, and I'm moving my body to the right. And you see the first stone has come out.
This is the beauty of the balloon sphincteroplasty, how nicely the stone came out.
Yes.
So thank you, Dr. Goenka. We are going back to the
Nice demonstration.
Thank you, sir. Thank you. Shift to, Professor Binmoeller, you are online.
Okay, good. So you can see there's a peristalsis in the small bowel. You can see there's some fluid there. We've already filled a little bit. And the first thing you need to do is get an appreciation of the fluoroscopic anatomy. And we've mixed some contrast in the fluid here. So the fluid is mixed with dye. That's just so that after we do the puncture, we can confirm that we entered the small bowel. And then we've added some contrast, which will create some peristalsis, unfortunately. So that's the only drawback of adding the contrast, which is the reason why I do all of this part in the very beginning through the oroenteric catheter. You know, it's basically a nasobiliary catheter, but we're inserting it through the mouth into the small bowel, not the bile duct. And I have it perfectly positioned at the ligament of Trice. So in this case, as soon as we get good filling with contrast, we'll get a fluoroscopic image. We're all lidded in the room. And so let's take a look with fluoro. Okay. Still not seeing, let's hold off one moment, wait.
With all of you, there was no
And it could just be it's so dilute. Yeah, it's just rarely dilute, but it's okay. We're seeing the small bowel. It's distending very nicely. We can see the oroenteric catheter there, right, at the tip. This looks very good. Stop now. Okay, now I give always half a milligram of glucagon first, and then when I'm ready to puncture, I'll give the other half. All right, so now let me have the 20 Axios. So what we ideally want to have is a trajectory that is, and I'll use the pedal here. So let me have now the Axios quickly, because we have now a fairly still, and we have a nice trajectory. You see, we want a longitudinal axis. That's the best, just like this. All right, let's have the 20 millimeter, and let's be quick, because once peristalsis starts, it's going to become a lot more difficult. So just remember that the small bowel is very mobile. The other thing is, if you need to instill very aggressively, but hold off for a moment. We're going to wait. So let me take, or you doing it? Well, Anthony is different. Anthony knows what he's doing. Okay, so it's been lubricated with some water, so it slides very nicely. And we lost that golden moment, but we'll hopefully get it back again. What's very critical is that you don't have an interposed loop, a small bowel between your target. And don't connect that yet. We only connect the cautery when we're ready to go in, so we don't accidentally. You know, I have all these pedals down here. So here I'm getting that trajectory again. Looks pretty good. And so we're going to check our settings really quickly. We have auto cut, and I like effect 7 and 100 watts. And then we can measure the distance, but I can tell it's going to be good. It should be under a centimeter. All right. Now the first step is to advance the sheath out. Just make sure you're not advancing against any resistance. So there it is. You see the tip lengthwise. All right. So now is where the most important is that you very aggressively distend. So here, okay, we'll put the water. Is this the water? Okay, good. I'm just going to very aggressively descend now. I'm going to have an assistant hold my scope just like this. You can see the feeding tube in there. So you see it's moving a lot, and that's the danger of this, is if you go and puncture at a moment that it's moving around. Did you give the other glucagon? You gave it or not? Give it now. We need a still bowel. And I just want to make sure, you're not tenting too much with your sheath. And then now we're ready to make it hot. Go ahead and connect. So now it's just waiting for that golden moment, right? When you have a nice longitudinal view, hold the scope like this, very aggressively. Okay, now I'm ready to go in. You keep stepping on the pedal, please. Keep stepping on the pedal. Hold the scope. A lot of movement here. So this is the tricky part, you know? Let's wait till the glucagon really takes effect. Okay, this is good. Now it's looking good. All right. We start to go through. I'm giving cautery. 1 second. I'm going to have to wait till this distends a little bit better, because I'm not seeing. Slow and steady. I'm not seeing any of. I saw the bubbles. I'm in. All right, good. So now I'm going to go a little as deep as I can go. That's why good. I go as deep as I can, like this. All right. So now I'm going to lock. We take off the safety pin, right? The yellow safety pin. And now we disconnect the cautery. Now we're going to deploy the distal flange very slowly. We'll just wait till we always do this under vision. Very good. Keep descending. Remember, this bowel is moving all the time. So now I'm going to advance the sheet just a little bit more, just to make sure that I have that. We call that the ramp. We talked about that earlier. 1 second. Okay, now we see the distal flange deploying. There, it snugs up automatically up against the wall. And I'm going to snug it up a little bit more until it deforms a little bit, because it's a little asymmetric. You can see the cable running through it like that, right? It's a little asymmetric, more on the bottom half than on the top half, all right? So now we can lock again, and we can deploy the proximal flange in the working channel. Okay, so I'm just slowly pulling this back, all very relaxed. Now the proximal flange is deployed in the working channel. Now this is the part where we switch to the endoscopic view. Switch to endoscopic, please. Make that big. Now I'm giving gas, right? I'm turning my body a little bit towards the right, giving gas, pulling away from the wall as I pull this scope back a little bit, and then very slowly, as I'm looking for the, I'm pushing it out. You can see it at the top. Just make sure that you do this slowly and you don't accidentally push it in. All right, now this part you can pull back a little bit and push again, and it pops out, or you can push the gray up down, and it both work.
Very nice.
So now you see the blue dye. So you know you're in the right place, right? You didn't accidentally go in the colon. So this looks very nice. You can see it draining, and the final step now is to dilate this tract up. And you don't have to, because I'll tell you this, if you dilate this, you get some pain. Patient often has some pain afterwards, and you may get some bleeding. So you could leave it and just let it dilate on its own. But if you have a patient who's very anxious to start eating, now when you pull out the cable, what's very important is that you watch and do this under endoscopic guidance. Here you can see very nicely the micro wires that run along the bougie-shaped nose cone, and they converge at the tip. That's what gives you that scalpel effect that we talked about earlier. All right, so now using the same scope, we can take a CRE balloon. You can typically use a 15 to 18, and we can dilate up this lumen. So that's optional, right? Whether you want to do that or not. So just to recapitulate, the most important is to be patient. And you have to wait for that golden moment when you have good visualization and you see the lumen in its trajectory longitudinally. And that's really going to give you the greatest rate of success. And if you don't see the bubbles, or you see the axios, can I have the CRE, please? If you don't see those bubbles or the sheath going into the lumen, just sit there for a moment, wait, don't keep pushing, because if you keep pushing, you will push the small bowel away, and then you may make it actually impossible to penetrate through, and that can lead to maldeployment of your distal flange between the small bowel and the stomach wall. Now, if that occurs, it's not the end of the world. If you see that the distal flange is deploying outside of the small bowel, you can resheath. And it's very easy to resheath. Okay, so I'm going to insert the CRE.
Professor Binmoeller.
Yes.
EUS-guided GJ is always through transverse mesocolon.
I'm sorry, I didn't understand.
You always puncture transverse mesocolon if you want to puncture any small bowel loop jejunum from the stomach. This stent go through the transverse mesocolon?
Oh, absolutely it can. That's why you need to be very certain about your anatomy. That's why it's important to both, confirm with fluoroscopy and with ultrasound. So yes, it has happened many times to many of us where you accidentally go through the colon. That can easily happen.
Mesocolon, not colon.
Ah, you're saying the mesocolon. Not the colon itself?
Yeah. We learn that and we monitoring the cellulite and teeth.
Professor Binmoeller,
Yeah,
Are you finished or can we shift?
I'm just going to dilate. So you can do this all with your ultrasound scope. You just need to hook the axis with the, and I'm just having a little challenge doing that, trying to hook it here because of the axis. Okay, yeah. If you, usually I can do it with this, but sometimes it's a little tricky. So you see here, you don't want to go through the mesh. Here we go. Now I'm going to get it. Good, I've got it. Okay, advance the wire a little bit. Just look and see. Perfect. Not too far because you don't want to push anything out. Now, when you push in, don't push against too much resistance. Just make sure that you got most of the balloon, enough of the balloon, I should say, inside.
How much you gonna dilate?
We'll go up to the full 18, but we'll start it in increments. So first with 15, please, so you can start to dilate now. And when you dilate, you want to keep yourself as perpendicular as you can. So dilate to 15, please.
Yeah.
Good. So it saddles very nicely, right? Good. And I'm nice and perpendicular. You can push in a little bit to keep that perpendicular. All right, go up to the next level. Okay, 16 and a half, right? No? And then 18. Good. And, my nurses usually say, I got some, some resistance or so, and we'll just wait till it gives. All right, 18, go down. All right. And then after this, we should be able to look very nicely into the small bowel, and usually you'll see the afferent and efferent. Good, okay, but it's not deflating. Deflate, please. Yeah, so this is not like a stricture where you need to keep it inflated for a minute or so. You just immediately go up and then go right back down. Do you want to minimize the risk of bleeding? So we're just deflating, and as soon as it's deflated, so here too, you need to do this with patience. Don't go just pulling this out because you can dislodge the lambs, the axios, and that's the one thing you want to avoid. So you'll see there's some bleeding here, but that's okay. The silicone covering should sufficiently tampen on that, and you can see now, look at that, right? You can see the afferent and efferent limbs there. The afferent is probably to the right and the efferent to the left. So it's a beautiful view of your gastroenterostomy. And
Great,
we're done.
Professor Binmoeller.